Hi there. For those of you who don't know, my name's Ashley. I'm one of the occupational therapists working right now at Children's Hospital and at Health Science Center NICU. Today, I will be doing a presentation called Occupational Therapy Practice in the NICU, Therapeutic Supports. So this is one of the presentations that has been revised by myself and my colleague Jenna Nixon, who is currently on maternity leave. But we'd like to give a special thanks to Diane Stanley and Brannigan LaPla for their original presentation. So who we are. So the NICU OTs cover by pod, not by service. There are currently 2 of us working in NICU while pod A is not being occupied. So I cover pods B and C, and Sarah, who is covering for Jenna while she's on maternity leave, covers pods D and E. So each of us as therapists cover wards in children's, so we are often back and forth between NI and children's. We work Mondays to Fridays from 8 a.m. to 4 p.m. And 1 OT is on call each weekend and 4 stat holidays. So for more urgent concerns, they're able to call the on-call OT, have questions, talk things out, if there's a new consult to inform us of this. If they have questions about feeding plans that we've posted over the weekend, they can feel free to call us. We actually appreciate getting a call on the weekend if they want to make a change to the feeding plan so that we can confirm or talk things out together. Sarah or Jenna typically carries a cell phone. Currently, I'm still using a pager, but will eventually transition to a cell phone. So for right now, you can call us through Vocera saying pod, the letter you're looking for, occupational therapy. And to call the weekend on-call therapist on your Vocera, you can say weekend pediatric occupational therapist. For new referrals, you guys must call or page us and speak with one of the OTs directly. If a referral is made in EPR only, we won't know about it. You can also call us or catch us in the pod to ask us general questions about feeding, development, or positioning, and help determine if a referral is indicated. So objectives. So to understand the role of occupational therapy in the NICU, to identify when to initiate a referral to OT, to review gestational development and skill maturation of the preterm infant, to enhance current knowledge of oral feeding supports with special attention to the preterm infant, and to review nursing-led feeding practice, including sync and semi-demand feeding. So the role of OT in the NICU. So occupational therapists look to support engagement in occupations. So for infants, their main occupations include eating, sleeping, and interacting with their caregivers. We promote and enable function in the infant whose behaviors and course is atypical. We monitor and assess development in high-risk infants. Our criteria of high-risk infants may include infants born less than 28 weeks gestation at less than 1,000 grams, those with central nervous system abnormalities, certain genetic conditions, and so on. We provide support and education to staff and families regarding quality feeding skill development and safety. We support development appropriate for their age and provide strategies for positioning. We promote engagement and bonding between infants and their caregivers, and occasionally to provide musculoskeletal assessment and splinting to minimize risk of contractures and deformities. So development. OT assesses closely with physiotherapy with a focus on skills affecting the ability to feed, sleep, and engage with their caregiver. This includes a focus on state regulation and postural control, as well as infant-parent interaction. We will also monitor development of tone, range of motion, gross motor, fine motor, and visual motor skills in high-risk infants. and we will determine the need for ongoing community follow-up and send referrals as required. So musculoskeletal assessment and intervention. So we are assessing the risk and concerns for contracture, formation, and prevention of deformity. So we may consider splinting to maintain and achieve range of motion goals. There is an increased risk of skin breakdown in preterm infants from their fragile skin, decrease of cutaneous structures. Often the risks associated with splinting outweigh the benefits for premature infants, so we may recommend range of motion stretches instead. Splinting can also impact caregiver-infant bonding if they're fearful of the additional aspect of care. So splinting may be more appropriate closer to or following hospital discharge. So feeding in the NICU. So this is a big thing about what we do. So occupational therapy supports feeding in the NICU, but generally feeding is initiated by nursing. The goal is for infants' caregivers to be the primary feeder with nursing support. We become involved when the infant is not following what we would typically expect based on gestational age or when there are safety concerns with feeding. In NICU, we follow SINC, which is the Safe Individualized Nipple Competency Protocol, and semi-demand feeding while the infant is learning to eat. We will talk about SINC, semi-demand, and ad lib demand feeding later on in this presentation. So feeding in the NICU, collaborative care. So when OT is involved with an infant for feeding, we want to work with the caregivers and nurses through assessment and intervention. This means developing feeding plans as a team to ensure success and buy-in. We will often have nurses and caregivers feed during the assessment so that we can auscultate and make changes, such as different bottles or nipples. Having the parent or caregiver feed when they are here will encourage consistency, which can help infants to learn the skills of feeding more effectively. This also gives the caregiver an opportunity to develop their skills and comfort with their infant. Communication is also essential for being collaborative with feeding. We are really appreciative of any qualitative documentation regarding feeding. So this is especially important if any changes are made on nights or weekends because we will not be able to discuss the rationale with those nurses. So we can better create and progress plans when we have all the information. So quantitative information alone, like volumes, does not provide us with enough information on feeding skill development. So please be prepared to feed the infant when we come, and that will come and support you guys rather than expecting the OT to do the feed during the assessment, as we're often running between feeds, and having the opportunity for us to auscultate and make those changes is really helpful for us. So feeding skill development. So nipple feeding is a complex, highly coordinated sensory motor experience for the preterm infant. That's by Ludwig and Weitzman, 2007. So gestational development of feeding skills. So it's relevant to understand when developmental skills emerge related to feeding when considering preterm infants. So some skills do not emerge or mature until after the preterm infant is born. So knowing gestational development of feeding helps us create realistic expectations for the infant. The development of feeding and swallowing is highly complex. It begins in utero and continues to develop into early childhood. So hands to mouth activities as soon as 10 to 12 weeks gestation. Pharyngeal phase of swallowing is seen as early as 10 to 12 weeks gestation. Suckling can be seen at 18 to 24 weeks gestation in utero. And readiness cues emerge around 28 weeks of gestation. Some suck-swallow coordination begins around 32 to 34 weeks, but it does not mature until 34 to 36 weeks plus. So it is not unusual to still see discoordination past term. So mechanics of sucking. So next we'll talk about the mechanics of sucking. This is applicable to both breast and bottle feeding. So movement of fluid out of the bottle or nipple occurs due to pressures. So positive pressure or compression pushes the fluid out of the nipple, where negative pressure or suction pulls the fluid out of the nipple. In most cases, the infant's mouth can generate both types of pressures. The tongue compresses the nipple, creating positive pressure, which pushes out liquid into the infant's mouth. When the mouth is sealed around the nipple, the infant enlarges their oral cavity with their tongue and jaw movement, which pulls fluid into their mouth. In order to create that negative pressure, the infant needs a full seal around the nipple. So how the infant uses these pressures to transfer milk can determine other feeding interventions required, such as the use of a vented bottle, which we'll talk about a little bit later. So suck, swallow, breath coordination. Sucking, swallowing, and breathing are all complex tasks which the infant needs to learn to do in a coordinated manner. So coordination is essential for prevention of aspiration and efficient food intake. Sucking, swallowing, and breaths occur in a 1:1:1 ratio within 1 second, meaning that they will suck, swallow, then breathe in sequence, all within 1 second. This is a lot of work and coordination, especially for a preterm infant. They will often have difficulty with this coordination, which was mentioned before, only starts to develop around 32 to 34 weeks and isn't fully matured until closer to term. So we use different interventions and therapeutic supports to help the infants with coordination and skill development. So you can think about feeding like running a marathon. It takes time to train. So anatomy of a normal swallow. So here's going to be a little video of the anatomy in the swallow.
Swallowing, or deglutition, is the process by which food passes from the mouth through the pharynx and into the esophagus. As simple as it might seem to healthy people, swallowing is actually a very complex action that requires an extremely precise coordination with breathing, since both of these processes share the same entrance, the pharynx. Failure to coordinate would result in choking or pulmonary aspiration. Swallowing involves over 20 muscles of the mouth, throat, and esophagus, which are controlled by several cortical areas and by the swallowing centers in the brainstem. The brain communicates with the muscles through several cranial nerves. Swallowing consists of 3 phases. Oral or buccal phase. This is the voluntary part of swallowing. The food is moistened with saliva and chewed. A food bolus is formed and the tongue pushes it to the back of the throat, the pharynx. This process is under neural control of several areas of cerebral cortex, including the motor cortex. Pharyngeal phase starts with the stimulation of tactile receptors in the oropharynx by the food bolus. The swallow reflex is initiated and is under involuntary neuromuscular control. The following actions are taken to ensure the passage of food or drink into the esophagus. The tongue blocks the oral cavity to prevent food from going back to the mouth. The soft palate blocks entry to the nasal cavity. The vocal folds close to protect the airway to the lungs. The larynx is pulled up with the epiglottis flipping over, covering the entry to the trachea. This is the most important step since entry of food or drink into the lungs may potentially be life-threatening. The upper esophageal sphincter opens to allow passage to the esophagus. Esophageal phase. The food bolus is propelled down the esophagus by peristalsis, a wave of muscular contraction that pushes the bolus ahead of it. The larynx moves down back to the original position.
So that was just hopefully a little video that was helpful to see some of the anatomy of how a swallow occurs. So moving on to the next section, which is the feeding assessment. So for feeding assessments, we are assessing multiple factors before and during each feed. Some of these factors include postural control, state regulation, oral motor anatomy, oral motor skills, non-nutritive suck, and nutritive suck. We assess through clinical observations, reading cues and stress signs, physiology, and auscultation. We will occasionally use video fluoroscopic swallow studies to assess swallows, but rarely in the NICU due to the risk of radiation on preterm infants. So postural control. Postural tone is relevant to positioning for feeding. So we aim to provide the preterm infant with supports to maintain physiological flexion. So physiological flexion means flexion at the arms and legs rather than a retracted position. This position is more similar to positioning in utero and promotes neuromuscular development and self-regulation. Lower body tone develops at 30 to 32 weeks, and the upper body tone develops between 32 to 34 weeks. State regulation. Infants need to achieve the right state to feed effectively. So we practice cue-based feeding in the NICU, which means that we watch the infant's cues to determine feeding readiness. State control is a continuum, as you can see here. We would like the infant to be near the middle for feeding. So calm, awake, and alert. So the modified Anderson state scale was designed to measure and describe states of preterm infants. So there are 12 descriptors based on body movements, regularity of respiration, openness of eyes, and muscle tension. When the infants are assessed to be at a 1 to 2 or the 11 to 12, so the top 2 or the bottom 2, they are not showing readiness to eat. When the infant is at a 3, so the eyes closed, sucking, to a 10, fussing, we can assume that they will be able to organize themselves enough to eat. This is a video of a disorganized state.
Can you get your hand? Yeah, I want to show a good route. I probably should have had her hand a little bit more. Maybe stop again. Come get.
And now here's a video of an organized state.
There we go.
No, I saw it. Okay. Okay.
Okay, so readiness signs. So readiness signs are indicators that the infant is showing readiness for feeding, including being awake, quiet and calm, bringing their hands to their mouth, sucking on their fingers or fist, grasping at blankets or someone's finger, curling up into a ball while lying on their side, staying calm or becoming calm when offered the soother, and maintaining physiologic stability. On the other hand, we have stress signs, which are the infant's way of telling us that they are overwhelmed and can't handle what is going on around them. So these might include physiologic instability, stop sign hand, so wide splayed hand, increased respiratory rate and increased work of breathing, mottling, hiccups, gagging, or grunting, straining or grimacing, coughing, sneezing, yawning, or sighing, shutting down or looking glassy-eyed, staring or looking away, looking panicked or fussing, sticking their tongue out, or arching their back. So what happens if we don't follow infants' cues? Well, we can cause issues in the future and entrain dysfunctional feeding. We might see loss of physiological stability, including tachypnea, bradycardia, and apneas. Infants may become disengaged and lose interest. There is a risk of oral aversion. So it's much harder for us to reverse oral aversion than it is for us to take a short break from feeding and then reinitiate it at a later date. So we can risk aspiration if the infant is not engaged in showing readiness, and we might be promoting poor oral motor skills that can lead to long-term consequences. So this can cause issues in the future if food with higher bacterial cultures are aspirated into the lungs. So we don't want to do that. So here's another video of an infant showing signs that they are not ready, so showing aversion and disengagement with taste. So you can see that the babe is not rooting to the soother and is averting his eyes, grimacing, and gagging. Some of those stress signs are pretty subtle, so it's important to be familiar with them.
He's a little more awake now. Some milk, Mm-hmm. Oh, oh goodness. Should I try again? No, I might give him a minute there because I think he just kind of choked.
So non-nutritive sucking versus nutritive sucking. So while on non-nutritive sucking and nutritive sucking look similar, there are several important differences. So non-nutritive sucking is when the infant sucks without receiving any nutrition. So this might be on a pumped breast, a gloved finger, or a soother. The purpose of non-nutritive sucking is for state regulation, to satisfy their sucking urge, and for sensory exploration. The purpose of nutritive sucking is to obtain nourishment and can be done at the breast or the bottle. Both non-nutritive and nutritive sucking consist of sucking bursts with pauses. So non-nutritive sucking is generally faster, about every 2 sucks per second, while nutritive sucking occurs at about once per second as the infant needs to also coordinate swallowing and breathing. So non-nutritive sucking is one of the first things that we assess. So we're looking for infants to be able to maintain stable vitals, tolerate handling, and achieve an organized state while sucking on a dry soother. We want to consider the quality of the non-nutritive suckle. So are they able to create suction, or are they munching on the soother? So compression alone can indicate an immature suckle. So are they able to achieve a rhythmical suckle, meaning they take several sucking bursts of 3 or more sucks with breaths in between? Can they modulate suction, meaning can they keep the soother in their mouth independently for a few sucking bursts? Suckle and suction become stronger as the infant matures, and longer sucking bursts and the ability to keep the soother in their mouth is a good indicator to start oral feeding. So feeding-induced apneas. So when nutritive sucking starts, the infant has to coordinate a suck-swallow breath, which is quite complex. So something that we can see in preterm infants is poor coordination and feeding-induced apneas, or known as breath holding. So this happens during the sucking burst. So the infant is doing a suck-swallow pattern without taking a breath. So following the sucking burst, the babe may start breathing heavily or faster to take in more oxygen than that they didn't get during their sucking. So we might also see desaturations or bradycardias. It is fairly common in preterm infants, and we use strategies to promote better breath control, including slowing the flow and pacing. So clinical indications of swallowing dysfunction. So some of the clinical indicators of swallowing dysfunction include choking during swallowing, pooling secretions, noisy or wet or congested upper airway sounds, multiple swallows post-suckle, apnea and desaturation with swallowing. In preterm infants, this occurs with disorganized suck-swallow breathing. Respiratory compromised infants are particularly vulnerable, especially as they fatigue or if they are structurally or functionally having anatomical anomalies. Swallowing dysfunction may warrant a video fluoroscopic swallow study, but as discussed earlier, we may wait until they're older. So feeding interventions. So supporting feeding progression. So we use various interventions to support feeding progression. So this can include positioning, environmental modifications, sensory motor and oral motor stimulation, external pacing, cheek and chin support, and nipple and bottle choices. So positioning. Physiological flexion promotes neurodevelopment and self-regulation. So we can help preterm infants focus their energy on feeding with positioning. So we position in flexion, midline containment, mimicking positioning in utero. Often we achieve positioning and containment through bundling, particularly when bottle feeding. When breastfeeding, infants can be unbundled as mom's body can provide positioning and containment. If an infant is too warm or sleepy with bundling, try just a shoulder bundle alone because they might be able to, that might provide them with that same feeling of containment as they would otherwise. We often feed in a sideline position where the infant's head is slightly higher than their feet. So sideline supports physiological stability, helps regulate the milk flow by minimizing the effect of gravity, and is more similar to breastfeeding positions. So we want to make sure their whole body is in sideline, not just their head. So nose over toes or stacked right on top of their shoulders. So here are just some pictures of infants bundled and unbundled during feeding. The bundled infants appear calm and organized, while the unbundled are showing stress and disorganization. So environmental effects. Premature infants are used to the muted uterine environment, so they now have to deal with light, noises, handling, movement, and more touch sensation. So some stimuli can be overwhelming for the preterm infant. So we can help decrease stimuli by dimming the lights, reducing extra sounds like TV or us having low talking voices, and minimizing touch and handling. This includes minimizing jiggling of the soother in their mouths. So also consider limiting handling before feeding. So you may need to do a diaper change following the feed. Let's see if this video will play for us.
More of a noise, a clucking as she breaks her seal. If I let go, she's going to shoot that soother out. So we're not really getting, so I'm just going to do a little bit of gentle. You can see she gets some suction. Not great, she's not sustaining it. There, we're getting better now. Starting, hey sweetie. Well, I want her to have some time to get it more. I can feel now that I let go, she's holding that soother.
So sensory motor oral stimulation. This is used to maintain positive oral sensory experiences. So some studies have shown that oral stimulation, in addition to non-nutritive sucking, will enhance the first initiation of oral feeding and achievement of full oral feeds. Oral stimulation plans involve stroking of the peri and intraoral structures, facial massage, and offering the dry soother. Offer the soother during the gavage feed to associate sucking with a full belly. A common question is when to transition from a preemie soother to a newborn soother. So if the infant is getting ready to start oral feeding practice, you should be trying them with the newborn soother. Once they start bottle feeding, open nipple, or breastfeeding, they will need to be able to manage that larger soother in their mouth. So external pacing. So many preterm infants cannot coordinate their suck, swallow, breath patterns, so we use external pacing to help them learn. So pacing is a facilitation technique. So as the infant suckles, the caregiver looks for missed breaths or infant distress. The caregiver will then tilt the bottle down to prevent the flow. The nipple remains in the infant's mouth as it can be disorganizing to remove the nipple during pacing. We're providing the infant with cues to stop the suckle. This can facilitate motor learning if the infant is paced regularly. This is a skill that can take some practice for both the person feeding and for the infant. And it requires the full attention of the feeder. So here's another video. And in this video, the infant was not taking pauses in sucking bursts. So the feeder provided external pacing by tipping down the bottle. The feeder waited until the infant stopped sucking and took a recovery breath before tipping the bottle back up. So give it a watch.
We're pacing her a little bit. She's not stopping, so I had to give it a little bit more cueing by tilting the bottle further. And we need to have it ready.
So you did a combination of tilting her and the bottle at first so that...
And she's now pacing herself already after 5 seconds. Good girl.
So next is chin and cheek support. So chin support, caregivers place their fingers under the chin and provide firm upward pressure, used to stabilize the mandible, inhibits the jaw excursion. Where cheek support, the caregiver's fingers are on the outside of the cheeks and applies firm inward pressure. This increases suction and pressure by decreasing the intraoral space. However, you need to consider why you are using chin or cheek support. While it can be helpful to improve the seal, there may be other reasons why the infant has a poor seal. So consider if the flow rate is too fast, if the infant is having issues with coordination, or if they are disengaged. So we typically would not be starting chin or cheek if they become sloppy mid-feed. This sort of suggests that they're fatiguing, and we would want to then be watching their cues and stopping. So what we would expect is that the infant would require chin and or cheek support throughout the entire feed. So this is another video, which is an example of chin and cheek support. Partway through the video, the infant starts to show stress signs, including increased respiratory rate. So as the infant is disengaging, it would be an appropriate time to stop the feed rather than continuing to use chin and cheek support to keep the infant latched.
Still a little bit worried, okay?
Edwin Esteban, Edwin Esteban.
So I'm going to write myself a note. So for her, during this period where she looks a little more worried, her respiratory rate's gone from the 20s to the late 40s to 50s.
She can't really keep a good seal either.
No, she's kind of lost it because I think she's like her own motor skills. So I'd say let.
So nipple choice. So research on healthy preterm infants shows that infants will adapt to any nipple. Nipple confusion is not typically a concern. Nipples are chosen based on the infant's skills and challenges. So it's important to consider parental preferences as well. So please encourage families to bring in their home bottles early if they have them. There is significant variation in firmness, shape, size of hole, and venting, all which affect the flow rate. The flow rate is often the deciding factor in finding the correct nipple for the infant. There continues to be more options available commercially. So we typically recommend trialing a feeding program for a minimum of 24 hours prior to discharge to ensure no issues once they're home. So for example, use their planned home bottles in hospital for at least 24 hours before they go home to make sure there's no issues. So flow rates. So fluid flow during sucking is a key factor in breath swallow control. So previous OTs had compared various commercial nipples to our hospital Enfamil nipples. It was found that the flow rates varied significantly between brands, and there can be inconsistencies within brands. So it's important to remember that one brand of slow flow is not the same as another brand. The extra slow flow and slow flow Enfamil nipples that we use in hospital, so the extra slow flow being the purple one pictured and the slow flow being the green or turquoise one pictured, are not available in the community for purchase. So infants using them in hospital will need to be transitioned onto an appropriate home bottle before being discharged. If you guys are unable to progress an infant to a standard flow nipple, that would be an appropriate time to consult OT. So flow rates, too fast or too slow? So too fast. When an infant breaks their latch, often during the seal, pulls off the nipple, especially with milk still in the mouth. Milk pools and runs down the side of their mouth when or during their feeding. And then stress signs, coughing, choking, sputtering. A nipple may be too slow if they're sucking very hard, so they might collapse the nipple. They might have increased respiratory rate. They might not be transferring very much milk despite actively sucking. They might get frustrated and pull off the nipple, and they might have multiple sucks per swallow. So vented versus non-vented bottles. So vented bottles, such as the Dr. Brown's bottles, maintains equal pressures between the bottle and the infant's mouth. So this means that there is a consistent flow which can help the infant get organized, as each suck is generally going to produce the same size bolus. So a vented bottle might be useful for infants with poor coordination, but it requires more effort, so it's not always appropriate for infants with limited endurance. So a non-vented bottle, such as the hospital Enfamil nipples, have variable pressures, resulting in inconsistent flow rates. It requires the infant to have more control over the bolus, but it requires less effort to draw the fluid out. Vented bottles are not necessarily are not necessary for or appropriate for all infants. I know often we talk about that the Dr. Brown bottles just fixes everything, but we really need to consider why and which infant would benefit from a vented bottle and which ones would benefit from a non-vented bottle. So a valved bottle system. So a valved bottle allows fluid to flow in only one direction. This means that the infant can generate flow using just compression. So these bottles are generally used when an infant cannot create suction or has weak suction. So you will most likely see valved bottles with infants with craniofacial differences, such as a cleft lip or palate, cleft lip and palates, and those with hypotonia or macroglossia. If you have an infant with a cleft lip or palate, please consult the craniofacial team for bottles and education for caregivers. OT does not need to be consulted on these infants unless they are having safety or skill concerns after practicing with the specialty feeder. So for example, that Dr. Brown bottle in the picture with that blue little disc, that's the specialty feeder. So remember to feed these infants in an upright position for anatomy, for gravity to help the fluid go downwards. So wanting to know if anyone has questions at this point, because this would be a great opportunity before we move on to the next section of sync and semi-demand feeding practice. If you guys do have any questions, please feel free to call or email myself or Sarah right now, or Jenna when she's back from maternity leave, and we'd be happy to talk things out. So sync and semi-demand feeding practice. So this is a nursing practice used for infants learning to feed. OT becomes involved if there is atypical feeding progression or concerns with feeding safety. most preterm infants will follow sync and semi-demand feeding under the guidance of nursing. So objectives: understand sync feeding protocol and how to implement, understand semi-demand and cue-based feeding framework, be able to distinguish between when to initiate semi-demand versus sync, recognize readiness and disengagement indicators, and understand the clinical reasoning used to determine top up by 2. So eating and sync. So what is sync? Sync stands for Safe Individualized Nipple Competency. It is a nursing-led practice developed to guide caregivers and the healthcare team in supporting preterm infants to become skilled feeders. We are aiming to provide consistent, predictable, and quality feeding experiences while allowing for optimal respiratory supports. So this is the algorithm. You'll find it in the infant's Cardex, and we'll go through it in more detail. So first, we'll just go through a little history of sync. So it was developed in Alberta in 2012 by nursing to address feeding in infants with BPD who were needing CPAP longer. Because of the longer use of CPAP, infants were not able to start oral feeding until after the CPAP was weaned. The investigators had the question, can we help infants born at less than 33 weeks breathe and eat? They tried several different ways of facilitating eating while maintaining lung volumes, which were unsuccessful, but by 2013, sync was developed and rolled out to that health region. And then we adopted sync thereafter. So anticipated results. There were several anticipated results as the protocol was rolled out. So some hard indicators of success included gestational age of first PO experience, gestational age of full oral intake, age of discharge and length of hospital stay, breastfeeding rates, and GT rates. But then there were also some soft indicators, which included more family engagement, confidence, and satisfaction, and positive oral experiences and happier babies. So who is sync for? Sync is initiated for infants born before 33 weeks, but can be started at a later gestation as well. There will be some infants that are outside of the less than 33 week criteria that might benefit from sync. So for example, an IUGR 33 to 35 week infant, or a patient that was born at 33 to 35 weeks who required mechanical ventilation may also benefit from the stepwise progression of sync. The decision to use sync with a non-typical infant should be made in collaboration with the interdisciplinary team. So your CRN, your RN, your RD, your OT, your MD, etc. If the team decides to use sync with a non-typical infant, it is super important that the plan of care is clearly communicated to avoid setbacks caused by starting and stopping sync. So it's started on both infants with or without CPAP or high flow nasal cannula. It is not for intubated infants. Sync should be continued even after CPAP or high flow nasal cannula is weaned. The infant should be physiologically stable and showing feeding readiness cues. Those feeding readiness cues begin at around 28 weeks gestation, so they can begin sync A on the pumped breast or the dry soother as soon as 28 weeks if they are showing feeding readiness signs. Preterm infants will be at various gestational ages when they start to show feeding readiness, so some as early as 27 weeks, some might not be till closer to 40 weeks if they have been intubated for a prolonged period. We know that soothers and a pumped breast may be offered earlier, which is fine, but it is more for comfort and bonding than feeding skill development at that time. So here's the sync algorithm. So sync A, once the infant is showing readiness cues, often around that 28 weeks, sync A can be initiated. It is considered successful if the infant can maintain physiological stability with latching and brief non-nutritive sucking on a pumped breast or a dry soother. So we will often see some disorganization initially as their skills develop. Sync A will continue until the infant can demonstrate sustained sucking without stress signs or disengagement cues. Next, once they're able to do that, they will move on to sync B and C. So once the infant has achieved sustained non-nutritive sucking, they can move on to sync B. It is often, it's usually only appropriate coming closer to 32 weeks of gestation. Sync B and C are similar in that they are considered therapeutic tasting. So the infant will be offered an appropriately pumped breast or drops on soother. If the infant is showing any signs of distress or disengagement, stop offering the drops and top up by gavage. So at sync B, the infant can take up to 5% of their total volume by drops, and by sync C, the infant can take up to 10%. Breastfeeding volumes with sync B and C are considered a gift, so top-ups will be their total volume. So sync D. Once they're able to successfully complete soother drops, they will progress to sync D, which is using an open nipple or sucking on an appropriately pumped breast. Using the slow flow nipple, you will apply drops of milk from a syringe into the open nipple. While the infant is sucking, keep the nipple half full. Offer 1 drop of milk at a time. Give them time to take breaths before offering more. If the infant is physiologically unstable, please return to therapeutic tasting. Just a reminder to please stop if the infant is showing any signs of decompensation or disengagement at any sync level, but this is especially important at early stages of sync because we are working on skill development and positive oral experiences. Volume is not our priority. So sync E to K. So when the infant is able to consistently and safely take 15% of the feed volume in an open nipple, you can offer the bottle with a slow flow nipple. This may also be done via breastfeeding. The sync levels increase in time and percentage of volume. The infant should slowly progress through the remaining stages. Once the infant gets to sync L, which is known as semi-demand feeding, they are able to feed for a maximum of 30 minutes. So advancing on sync. Now that we've gone through the sync levels, we'll talk about how and when the infant is ready to advance to the next stage. So in order to advance, the infant must successfully complete the sync level requirements in 6 out of 8 feeds in a 24-hour period, assuming that they're feeding every 3 hours. If they feed every 2 hours, they'll need to complete 9 out of 12 feeds. Slow, conservative approach at early stages of sync helps the infant to build strong basic skills that allow for quicker advancement at later stages. However, the opposite is also true. Rapid advancement through early stages can lead to stalls in later stages due to aversions or being pushed too hard too fast. It is very normal for an infant to stay at a level for several days to develop their skills. Also, don't be afraid to hold or not advance an infant if they have a history of tuckering out. We want to focus on the quality of feeding opportunities rather than the quantity. If advancement is offered and the infant doesn't appear to be doing well, example, a few quote unquote fails in a row, move them back to the previous stage for a day before trying to advance again. We want them to be successful. If the infant is repeatedly unable to advance, consider consulting OT. Something else I just want to say is we're currently working on updating our sync and our language with sync. So the words pass and fail is often very hard for families. And what we want to start working towards is explaining to families that they were either successful in the time period with that volume at that given feed, or they weren't able to achieve all states of calmness and able to efficiently transfer the volume required in the given time period. That doesn't mean that they fail. It just means that they have another opportunity at their next feed to try again. So this is the form nurses use at each feeding opportunity, which you'll find in the Cardex or the bedside binder. You will simply put a check mark if the infant was successful or an X if not. On the back of the checklist, there are more details about sync progression, therapeutic tasting, breastfeeding on sync, and readiness and disengagement cues. So readiness and supports. So a few tips for providing developmentally appropriate supports during feeding with SYNC include providing postural stability through bundling, side lying, and physiological flexion, offering non-nutritive sucking before offering the nipple, and using a slow flow nipple. Also, infants should only ever be offered 2 modes of feeding per feed time. So for SYNC, this will mean offering the breast or the bottle with a gavage top-up. So breastfeeding on SYNC. So breastfeeding should always be offered as the first mode if it is what the caregiver wants to do. We never want a caregiver to think that they will go home faster on a bottle, therefore discourage breastfeeding. So for each SYNC level, the time offered is a maximum. The feed can still be considered successful if the infant breastfeeds for less time than allotted, given that they are physiologically stable, engaged in transferring milk. Top-ups with breastfeeding and SYNC are a common question. We can assume the maximum SYNC volume was taken based on assessment of milk transfer, mom's report of babe's latch and suck, the infant's ability to suckle and stay engaged while orally feeding. Speak to the team and the dietitian if questions around the top-ups and or weight gain. Pumping will vary mom to mom. So some moms may need to pre-pump to get milk flow started, less work for the infant, but other moms may need to pre-pump due to a strong letdown. Others may not need to pump at all. So SYNC and CPAP. SYNC should be progressed to SYNC B, therapeutic taste, once the infant is stable on CPAP +6 or less and is showing feeding readiness cues. So pressures higher than +6 are generally felt to be unsafe for therapeutic tasting beyond SYNC A. So in general, infants on CPAP should not progress past SYNC D unless assessed by an OT. If you feel the infant could progress further or they cannot be weaned off CPAP, consider consulting OT. If the infant remains on SYNC D, that's okay because their volumes will grow as they do. So SYNC D allows for 15% of their total fluid intake. So that will create more of a challenge even if they're on it for a longer period of time as they grow. If CPAP is discontinued, please keep them on SYNC. They will continue to benefit from the slow, consistent approach. Stop the feed at the first sign of stress regardless of the respiratory supports. Disengagement cues. So with SYNC and cue-based feeding, our main goal is positive feeding experiences. So we have a 0 tolerance for events. As mentioned, stop feeding if the infant is showing any decompensation, disinterest, or disengagement. Indicators to stop would be apneas, bradycardias, desaturations, increased respiratory support, stridor, tachypnea, increased work of breathing, turning away, or stop sign body language. By maintaining positive oral feeding experiences, the infant will learn to become a competent and skilled eater. If they associated eating with stress, discomfort, or fear, we can create an aversive eater. And as we talked about before, it's much harder to overcome an aversion than it is to create an opportunity to take a break and then start up again. So caution events. So we need to consider the infant's planned or recent workload prior to each feeding opportunity. This may include recent vaccines, exams, procedures, events, or transfers, whether it's between facilities or pods. They have less success following some of these events. Skin to skin can help them recover these events. So if parents are present, please encourage this. Quality eating. For all feeding experiences, the focus needs to be on quality of skill development. We use cue-based feeding approaches where we follow the infant's cues. Cue-based feeding is relationship-based, infant-driven, and promotes positive oral experiences. We appreciate that feeding is a developmental skill that the infant is learning and emerging. On the other hand, volume-based feeding is more of a competitive sport. So the focus is on how much volume can they get into the infant. The motivation is who can get more in rather than helping the infant learn feeding skills. Infants are viewed as good feeders if they can take a large volume, or they're considered poor feeders if not. So regardless of their actual skill, the culture of oral feeding, such as this, can lead to poor feeding skill development, increased infant stress and physiological instability, and adverse effects long-term such as aspiration and aversion. We know that there is lots of pressure for discharging patients for bed flow, but we want to make sure that infants have adequate skills before going home so they don't return. So this is a Calgary example pre-sync as a case study. So this infant started oral feeding at 33 weeks with small volumes of 1 to 2 mLs a few times per day. By the time they got to 37 to 38 weeks, they gradually increased to around 15 mLs. Once they reached 39 to 40 weeks, the team was eager to get them feeding more, as we've all seen, and he was offered more than he could tolerate. After a few large volumes, he began taking small or even no volumes. It is difficult to say if that one push caused the limited progression or if he would have naturally needed a prolonged hospital stay, but that is a pattern that we see here, but was often seen in Calgary. We see this, as we just said, in infants here as well. So they are offered inconsistent volumes or a few days of very large volumes followed by decreased volumes. So as we shared before, the goal is consistency. So let's see what we can do in our next example. So this is a Winnipeg case example demonstrating how allowing an ex-premature infant to overfeed can lead to setbacks. So as you see, sync was not used in this case. We're kind of unsure why. This example may be from before sync was implemented here. So this is baby W, who was born at 26 weeks. She spent 98 days in hospital, and her first oral experience was at 36 weeks. This is a bad example of slow and steady progression, but she was able to reach 100% PO and maintain her stamina for about 10 days. Then the baby was allowed to feed 160% of her requirement. She maintained her stamina for a few more feeds, and then she tuckered out and had a few full gavage feeds before going back to ad lib demand. So this is another Winnipeg example where sync was used. So this is baby B, an ex-26 weeker from St. Boniface, who was put on sync. Their first oral experience was at 34 weeks gestation based on queuing. While on CPAP, they were taking as much as 10 mLs with soother drops and open nipple. Once on nasal prongs, they continued to work on feeding and reached ad lib demand by 37 weeks. This is an example of slow and steady progression as well as consistency. So resources. So where in the pod can you find information on sync? There's various colored duotangs at the central desk in each pod labeled sync. They're all different colors, so just look for the label. If you have questions, so who might you ask? So a charge nurse, a CRN, an educator, an OT, a dietitian. There's lots of people around. Make sure you communicate so that you're upskilled. So moving on, so the next section is called semi-demand feeding. So what is semi-demand feeding? So semi-demand feeding is a method of transitioning to full oral feeds that is infant-driven and responsive to their cues and behaviors. The infant is given a chance to wake on their own within 30 minutes before or after their scheduled feed times. They're allowed to feed their full volume within a 30-minute time limit. If they are showing disengagement, stress, instability, or are unable to complete the volume in that allotted time, the remaining volume will be given by tube. Infants on semi-demand feeding will generally always have a tube, so an NG, occasionally an OG or GT. Gently unbundle them at 3 hours and attempt to offer non-nutritive sucking. If they are not demonstrating readiness cues, give them another 30 minutes and reassess again. If they are not showing readiness at 3.5 hours, then they will receive a full gavage feed. Semi-demand feeding is also developmentally supportive. Premature infants often lack the neurobehavioral organization of state regulation, respiratory regulation, postural stability, oral motor coordination. Feeding progress is based on maturity and physiological stability. By using semi-demand feeding, we are allowing them the opportunities to develop these skills. So we'll use The interventions and strategies we discussed earlier to support their feeding progress, such as pacing, positioning, chin or cheek support, or use of a specialty bottle. Some empirical evidence suggests that infants feeding semi-demand transition to full oral feeds sooner than other control groups. A successful feeding in an infant-driven model of care includes the achievement of 4 goals. The feeding is safe, functional, nurturing, and individually and developmentally appropriate. So that was by Ludwig and Weitzman, 2007. Semi-demand is also called cue-based feeding or infant-driven feeding. So HSC NICU often uses the term semi-demand, but in case you hear other terminology. So this is just a visual of the semi-demand algorithm. It shows a nice step-by-step way to determine the feeding assessment and process at this stage. Yeah, take a peek. This is a diagram that compares sync and semi-demand. So you can see that both methods are based on infants' readiness signs and disengagement cues. They both allow for 30 minutes on either side of the feed time to show readiness. With semi-demand, the infant is allowed to feed as much as they want within a 30-minute time cap. So semi-demand feeding. So the infant may be ready at one feed and not at another. That's okay. Do not expect them to take their full feeds right away. They might have an indwelling NG. So the feeding tube is a therapeutic tool to help keep oral feeding positive and safe. Use it if you need to. Success is measured by quality and consistent progression rather than volumes taken. So who is semi-demand for? So infants are eligible for semi-demand once they achieve physiological stability, including managing secretions, no increased work of breathing, minimal apneas, brady's, or DSATs with handling, and tolerating gavage feeds. The infant should only begin semi-demand feeding if their gestation at birth is greater than 33 weeks. If the infant was born prior to 33 weeks, they should have started sync. Infants born before 33 weeks will be eligible for semi-demand feeds once they have reached sync level L. So they will get there, they just need a little bit more time and that slow progression throughout the feeding journey. So feeding readiness indicators. So we're looking for an awake, quiet, calm state, as well as quiet, calm with handling. We may need to provide interventions as discussed earlier in this presentation to help them achieve this state. This may be through bundling, non-nutritive sucking. It may also take several minutes to achieve this state. So try to be patient if you have a few minutes. Infants should show feeding readiness cues, including rooting, bringing their hands to their mouth, sucking on their fists or fingers, grasping at blankets or someone's fingers, and demonstrating good flexor tone. Another indicator for feeding readiness is their oral motor skills. So we'd expect them to achieve at least some suction and maintain short sucking bursts, regular pauses and sucking at this point. Finally, we're looking for physiological stability, meaning they can maintain a respiratory rate below 70 with non-nutritive sucking, with no work or breathing, and that they're tolerating handling without apneas, brady's, or DSATs. So feeding readiness scale. So this is a feeding readiness scale that you can access in the flow sheets or in EPR online. You can use it as guidance if the infant is showing feeding readiness. The lower the number, the more readiness the feeding being shown by the infant. Yeah. Disengagement cues. So we are assessing the infant's readiness throughout the feed and will stop if the infant is showing disengagement signs. So some disengagement cues can include changes in state, such as fatigue, eye aversion, looking glazed over, motor stress, such as grimacing and finger splaying, loss of bolus control, such as gulping, choking, fluid loss, changing in quality of their suck, and physiological changes such as increased respiratory rate, increased work of breathing, or any sort of an event. Oxygen sats may dip slightly and briefly, which is to be expected in a premature infant due to feeding-induced apneas. However, a gradual decline in oxygen sats is indicative of an inadequate respiratory support. So even as increases of 10 beats per minute can indicate stress in the neonate, so even something that small. So increased stress results in poor control of the suck swallow and breath swallow coordination and develops inappropriate pathways, neuropathways for development. So if the infant is having significant physiological instability following a feed, then likely the work of that feed was too great for them. So this is a very quick video of an infant who is appearing disengaged. His mouth is hanging open, his eyes are glazed over, and he is not showing readiness signs. Watch carefully because it's a quick video.
And a mouth open. Oh. So we are now ready to stop.
So benefits of semi-demand feeding. So there's benefits for caregivers. So it allows caregivers to learn infant cues. It improved responsiveness leads to increased attachment and confidence for caregivers, and it promotes bonding. For nursing, it eliminates pressure to complete volumes. It eliminates pressure to feed a disengaged infant, and the consistency is across then all the caregivers. For the infant, it supports neurodevelopment. It's individualized and consistent. Positive associations with feeding. Promotes feeding of hunger and increased eating by mouth. And they may reach oral feeding faster, potentially shortening their NICU stay. So just a few tips for semi-demand feeding. So generally begin with the slow flow nipple. As the infant is taking closer to their full feeding volumes, please encourage families to bring in their home bottles. If they're having difficulty transitioning to either a standard flow enfimal nipple or home bottles, this would be an appropriate time to consult OT for assessment. Feeding plans should be used for a minimum of 24 hours before discharge when possible to ensure infants can maintain and manage that feeding stamina and volume with that flow rate. Commenting or documenting on quality of the feed rather than just the quantity. Also, please document if you're making any changes to the feeding plans. So ad-lib demand or on demand. So once taking full volumes consistently on semi-demand for at least 24 hours, the infant can transition to ad-lib demand or on-demand feeding. So this means that the infant can be fed whenever they are showing hunger cues rather than on a set schedule. So basically they can eat what they want when they want it. They will no longer have an indwelling NG, and there is no top up at this stage. So the goal is that the infant's cumulative feeds throughout the entire day sustains them. These are feeding milestone cards that may be presented to families or the infant. And I guess this is the end of the presentation, and we're wondering if you have questions. Again, if you have questions, we'd be happy to answer them, so please call or page us or reach out via email, and we'd be happy to chat. Thanks so much for listening.